So if we think sort of just right behind our forehead, or yeah, behind our forehead, that's what's referred to as our frontal lobe. That's really the part of the brain that sets us apart from animals. It allows us to have impulse control, so if we have a bad thought about our neighbor, we don't go out and do something about it. That's also where we have our abstract thoughts, so if we're thinking through a problem, that's where it's being filtered through. It's our attention to things, and our concentration happens in that part of the brain. It's also sort of the supervisor for the brain. It's where everything gets filtered through and put together. The other thing that's really interesting about the frontal lobe is it's not fully developed until age 25. So if any of you have teenagers in your life, this is often the reason that they don't recognize that there can be difficulties with some of their behavior. They have trouble with impulse control or understanding that there might be consequences. So for example, just a story that kind of resonates around that is my grandson is 21. Over the last couple of years we've been talking about, usually we're talking about his driving. Now he's a very good driver, but drives very fast. And I always talk to him about, you know, police could be there, you could get a ticket, there could be a dog or a cat or a child run out between the cars, that could cause you difficulty. And he says to me always, well, you worry too much. And I said to him, because you don't worry at all. And I've talked to him about his frontal lobe not being fully developed. So now if I touch my forehead at all, he says to me, yeah, I know, frontal lobe not fully developed. So that sort of explains why teenagers, and then as they get a little older, parents will often say, well, they sort of kind of grew up or things changed. That's what happens, that frontal lobe finishes growing. The temporal lobe, which is sort of right over our ears, and is often the one that's first affected when people have Alzheimer's disease, really is where language and memory are stored. So those are the parts of the brain where our memories are. It's also where our memories of smells, those kinds of things. So often people will say, you know, I smelt that and it took me right back to when I was a child and I had that memory. Somebody was telling me the other day that whenever you know, they smell cinnamon, they right away think of their little bakery in their town where they used to buy these great cinnamon buns. And that memory is brought up every time they smell cinnamon. So it doesn't have to be that there's cinnamon buns around, it's just the smell of the cinnamon. The parietal lobe, so sort of up just behind your temporal lobe and sort of at the back of your head, but not totally at the back, is your parietal lobe. And that has your reading and writing happens in that section. That's where that's stored. It's also how your body determines, that's where your 3D center is, so that's how you're able to figure out where your body is in space by the use of your parietal lobe. And then right at the back of that thinking part of your brain is the occipital lobe, which looks at, that's your vision center and your visual interpretation and recognition. That's what happens in that part of the brain. So when we look at what we're going to talk about, we're going to go into the 7 A's in just a minute, but one really important sort of statement around the brain and how it works is that our brain determines how we experience the world around us. For each of us, our reality is our reality. We can't convince other people that what we're seeing is what they see, and it's the same for people with dementia. Our reality is not their reality. And one sort of way of looking at that, or one way of thinking about our reality is, if you ever sit with your brother, if you have brothers and sisters, and you ever have a conversation with them, and you talk about perhaps your childhood, you can see that each of you remembers being a child quite differently than the others, or at least, maybe I should only speak about my own family in terms of looking at it. But I remember talking to my sister, for example, who said that she couldn't figure out what was going on with her kids. They were fighting all the time, and she couldn't figure out what the problem was. Because she said, as kids, we never fought, and she couldn't figure out what the issue was. And I said, well, what family did you grow up in? Because what I remember is us fighting all the time as kids, so it's just a different perspective. My reality is different than hers, and it's the same for people with dementia. In terms of looking at dementia, damage to different areas of the brain can affect behavior as well. So we're going to talk about those some in just a minute. We look at, when we're thinking about it, that all behavior has meaning. So thinking about for a person with dementia, if they have a particular behavior, what's the meaning behind that? Is it related to something that's happening to them in their environment? Is it because of pain? There can be many reasons why somebody's doing something. And sort of understanding the brain and what's happening in the brain and those losses can help guide our responses, give us a better understanding of the behavior and a better way of sort of thinking about how we might intervene in terms of looking at what we might be doing. So what we're going to talk about are these 7 A's. So when we're looking at the 7 A's, really thinking about them, you don't have to remember those words. Remember, you're going to get your presentation. And I'm going to just talk about what's happening for the person related to those A's. So the ones that we're going to talk about are loss of memory, and for most people they've heard the word amnesia, so we're going to talk about what that means for people. We're going to talk about loss of language, which is also referred to as aphasia. I think I got the water. And then we're going to look at loss of recognition, which is agnosia, and talk about what that means. Loss of purposeful movement, or apraxia, which is really difficulty with the everyday tasks that we do because parts get forgotten and it makes it more difficult. Here's no knowledge of their disease, which is anosognosia. The word sounds big and long, but anosognosia really means that the person doesn't understand that they have this disease happening. Altered perception is loss of perceptual acuity, and it's related to the changes that are happening in that 3D center in the brain. And then sort of loss of being able to get started, or apathy as it's referred to. So we're going to start going into talking about what each of those is about. So when we look at memory and we think about memory, it can be divided up into a couple of different things. When we think about memory in terms of short-term memory, it has a limited capacity, but it's really about 7 items, and that's why they say often that phone numbers were meant to be 7 digits, because that was the maximum amount of things that you could hold in your brain in short-term memory before it got transferred into your long-term memory. And now they've decided to make all of the telephone numbers 10 digits, so they've made it a little more difficult. In Manitoba, it's not too bad yet because it's still 204 and the number, but eventually they're talking about having another area code which will make it a little bit more difficult. So short-term memory is absolutely necessary for new learning because you need to be able to hold the information and then it gets into long-term memory. Long-term memory, on the other hand, has an unlimited capacity. Memory is put down in layers. And so when we think about how people lose their memory, typically it's the last thing that they learned or that was a memory, that's the first thing lost. And then the first thing that they learned is going to be the last thing that they lose. When we look at how we form a memory, it's really a 2-step process. The first part is that it's held in the brain, part of the brain near the temporal lobes that we just talked about, called the hippocampus. And you don't need to remember that, other than it's stored in the brain as short-term memory, and then it's taken and registered in another part of the brain to be stored. And so sometimes when you're thinking about somebody, if you're thinking about a person, for example, you might ask them, well, what did you have for breakfast? And they have difficulty with that. But they're able to tell you the dress that they wore to their Easter dinner 40 years ago. That's because the memory, the short-term, it's because the old memory, was stored, and that person can remember that dress and everything that went along with that. But the short-term, that memory of what happened in the morning at breakfast was never stored, and so they don't remember what happened at breakfast. So it actually really, when you think about the way memories are stored, it helps you to understand why somebody might be repetitive. They might ask a question over and over again because they actually don't remember that they asked the question, and they may also not remember your answer, so that can make it quite difficult in terms of looking at that. Even with long-term memory though, eventually for people with dementia, those memories are going to be lost. And they're lost in the reverse. So like I said, the last memories that they had are going to be the first ones that they lose. And the ones that they've had for a long time, those ones are going to be stronger. Typically what they say is that the strongest memories that we have are between the ages of 3 and 30. And often the reason that those are such strong memories is because there's lots of firsts that happen. So people can talk about the first day of school. There's also emotion tied to it. So either it's happy or sad events, and people can have those really strong emotions and can remember those events quite clearly. There's also two kinds of learning that can happen. We can have procedural learning. Those are tasks that you've learned how to do. And you can also have what's called habitual memory, which is well-learned tasks that sort of move out of our conscious awareness, and we do them without even thinking about them, like getting dressed. We can, though, for people with dementia, cause what's called unconscious learning or create these memory trails. So we can actually help somebody to remember things by doing things in the same way. So if they're having some difficulty with doing a particular event, you can use doing it in the same way over and over again every day can help them to actually continue to be able to do that. But when we're looking at those, remember I talked about those strong memories between 3 and 30, and if we're looking at how we might distract somebody or redirect somebody, we want to use some of those mountaintop memories, something that was a good memory as a way to help that person if they're distressed. Some of the things we want to avoid around memory is testing. I'm slouching, so I'm going to have to remind myself to sit up. In terms of looking at, I lost my train of thought. We want to avoid testing the person's memory. So in other words, if they're having difficulty with something, testing their memory can be difficult. You know, asking them, well, what did you have for breakfast? Sometimes people feel that's a good way of going, but that's probably not the best way. Reality orientation. So when I first started working in long-term care, that was something that we did all the time. Reality orientation was to tell the person, you're this old, you live here, this is happening to you. But it was often distressing to people because people who have dementia don't live in the past, but they have access to their memories when they're younger. So they may feel that they're 40. So for me to tell them that they were 80 and that they lived in this personal care home was actually very distressing to them and caused them difficulties. It's recommended that we more go with the flow, try to figure out where the person's at, and we might use distraction, something like a cup of tea, playing with the dog, something that's meaningful to that person in terms of what's happening. When we're thinking about something that's pleasurable to them, reminiscing about their early life, really validating how they're feeling, so giving them some sense that you understand how they're feeling about that. Encourage them with it by following through with whatever routines have they normally done, because that repetition, if it's their routine and that's what they've always done, that kind of repetition is comforting. For example, if I were to tell you right now, in this situation, that you weren't at this teleconference, that this wasn't happening, and I kept trying to tell you that, how would you feel about it? And for most people, we'd start to get frustrated. Recently I was somewhere and somebody tried to tell me that. It didn't take very long before I started to feel frustrated. So that's similar to somebody with dementia or Alzheimer's disease being told that they're wrong about something that they feel is true, because it's a long-established habit for all of us to believe what our brain is telling us. We trust our own memory first, and we're kind of hardwired to do that. So it's just the same for people with dementia as it is for people without dementia. So just a technique in terms of thinking about repetitive questions. If the person stops asking you after you've answered that question 10 to 20 times, then you can think that or conclude that that worked. If they stopped asking you after you distracted them 10 to 20 times, then you can conclude that that works. If neither works, then you would try putting the two together. So one short sentence, answer, and then immediately the distraction. An additional technique is to think about answering numerous times, and if the person is still asking the question, to write it down, write the answer down, again, one short sentence on a slip of paper and put it in their pocket. Just remember that, like anything, I'm talking about these memory losses, but they're not absolute. People can have good days and bad days, and sometimes they will seem much more present than other days. And at other times they're going to be back 70 years, which makes it challenging for us when we're around them. If we don't have dementia, what we need to be doing is adapting to what the time frame that the person's in, in the time frame that they're forced to be in because of the disease. But the ability to be able to do that and do it well really creates for that person a supportive environment. So we're going to start talking about the second change. Which is aphasia. So we're going to talk a little bit about language, which is both language, or that loss of language that happens with aphasia is really, can either be, for some people it's going to be verbal. One thing that doesn't change for people with dementia is really their ability to be able to read nonverbal communication. And when we look at what, often we're really worried about the words that we're saying, but more important really in all communications is really the tone of our voice and the way that we look. So one good way of sort of looking at that is just to think about, it isn't what was said to me. Most people, when they're upset about something and talking about a bad communication, it wasn't what was said to me, so it wasn't the words, but it was how it was said to me. So our nonverbal communication becomes even more critical for people when people have dementia. They're looking at us and trying to figure out, okay, is this person friendly or not? And we've been hardwired from caveman times to use nonverbal communication as a way for us to figure out what's happening. Speech and comprehension are located in two different parts of the brain, so depending on the type of dementia the person has, either speech or comprehension will be affected first. People who have frontal lobe dementia, it initially affects their language, and with people, or speech, and with people who have Alzheimer's disease, it's their comprehension. Any of these things can be affected, so understanding what people are saying, knowing what things are called, being able to think of the words you want to use to communicate, and then using them to say what you want to say. All of us can have that sort of tip of the tongue feeling, where we just can't think of the word at the moment that we want to say it. And then we go away from it, and we're sitting and we're having coffee with our friends, or we're doing something else, and then that word comes back to us. Often for people with dementia, they can have that tip of the tongue feeling and not have the word come back to them, and they can feel quite frustrated about them. Understanding what other people are saying is made worse in a room with lots of people talking all at the same time. So it might cause that person to withdraw socially if they're having difficulty sort of sorting out who's saying what. And things to avoid are more than one person speaking at a time. We shouldn't always assume, sometimes people are nodding and we're assuming that the person understands. They may be nodding because that's something that they learned early in life. That's a polite thing to be doing. It doesn't always mean that the person understands. They may not be able to report their needs or their discomforts. The other thing that we want to avoid in any conversation or discussion with people, though I said the words aren't as important, some of the words that we should avoid is any words that make the conversation sort of negative. So things like no, you can't, stop, don't. It makes us all react sort of and want to go against whatever that is. So our tone of our voice is really important. Our body language is important. So smiling, making gestures are also important. Being patient is really important and allowing the person time to respond. It can take at least 30 seconds for the person to be able to answer a question. So often if we're not giving them enough time, that can be a difficulty. And I would just give you, just when you go home or whatever, just think before you respond to a question, wait 30 seconds and see how long that takes. It really is much longer than we might anticipate. The other thing is just when we were talking about the body language, now hopefully you can see these pictures, but just thinking about this lady, for example, imagine you're in another country and you don't speak the language. Do you think this is the lady that you would ask for help to find your bank that you can't find? She looks kind of cranky to me. I'm not sure. Be more likely to ask this person, even if I didn't think that she spoke my language. I'm in a country and don't know the language. I'd be more likely to go to this lady because her body language is much more open and she's smiling, and I'd be hoping that she could understand what I was trying to tell her in terms of what I wanted to communicate. So the importance of the way that we look is important in all of our communication, not just for people with dementia. It's just kind of good. And if you ever want any feedback about the way that you look when you're communicating, I get feedback from the people that I work with, and I do presentations and I get some feedback, but probably the best feedback I ever get is from my family. So you'll come home and you look kind of grumpy, and then they ask you, are you grumpy? Oh no, I'm not grumpy. Well, yes, they see something in me that says that I'm grumpy. So the importance of thinking about the way that we look. Sometimes when we're communicating, the other thing is, a good suggestion that was made to me is just to kind of take a deep breath and then just think about how you're presenting yourself, and that can often make us feel calmer and more feeling like we can go forward with that communication. So the importance of that. So people have those losses, but if they feel safe with you, they're going to be okay with that kind of communication. So the next A that we're going to talk about is agnosia, which is a loss of recognition. So that loss of recognition, it can be of people, it can be of objects, and it can be of sound. So loss of recognition of people is often in the order in which they came into their lives. So people early in the disease might be that they forget their grandchildren. They would be forgotten first because they came into their lives much later, and that memory was put down much later. But one of the ladies that lived across the street actually from us at the lake, she had Alzheimer's disease. She talked to us on the street. My husband and I were outside, and she talked to us, and she said, isn't it wonderful that this young man is here helping us move in terms of what's happening? He's such a gentle and great guy. Isn't it great that he's here to help us move? I don't know how he knew that we needed to move, but he's here helping us move. And we knew that was her son, but she actually at that moment didn't recognize him. She had that agnosia. She didn't recognize him anymore, but she still saw him as somebody, because his body language, he was great. When he would look at her, he'd be smiling and just make that connection. People can have, sometimes they can even forget themselves, So sometimes people can actually not recognize themselves either. That agnosia or that loss of recognition goes to even not recognizing themselves, so they can for example, look in a mirror and not recognize themselves. So it can be a little distressing. So sometimes for people, Mirrors need to be covered because that can be distressing. They don't recognize themselves. And when you think about where mirrors are, it can be distressing because sometimes they're in the bathroom. You're in the bathroom and suddenly there's another person in the bathroom with you. They can have loss of recognition of objects. So a person with dementia might look at a fork and not know how to use it or what it's used for. So looking at it and sort of not thinking about how it's used. Or a comb, they might look at the comb and not recognize what it's for. They can also have loss of recognition of sound. So sometimes, we've had this sometimes in personal care homes where, for example, they'll get a cat and the person will think that the cat meowing is a baby crying, so not recognizing the sound, or not recognizing maybe the telephone ringing and could be sitting next to the phone and not pick it up because they don't recognize that the phone ringing is the phone ringing. And so they can be startled every time the phone rings. So what they recommend is really avoid testing a person's memory in terms of, you know who I am, they may not. And so always identifying who we are is good in terms of thinking about that. Meeting the person where they are in their memories. Sometimes in terms of objects, what they were talking about is the importance of cueing. So giving the person the object in the place where they're most likely to use it. So they might be, if for example it's a toothbrush, the best place to use the toothbrush is in the bathroom, brushing your teeth. So having it with the toothpaste on it, having them in the bathroom, all of those cues will help the person hopefully to still be able to brush their teeth, looking at that. So the next A that we're going to talk about is apraxia, or that loss of purposeful movement. So what does that actually mean? So it's that sort of loss of ability to sort of plan, sequence, and execute the steps of a task. And there can be multi-tasks, or multi-steps to a task. I was watching a videotape the other day at work, and they were showing about making a cup of coffee. And just from the whole idea of thinking about the cup of coffee and all of the steps, there were probably about 30 steps to making a cup of coffee by the time you thought, just going from thinking, sitting and thinking about having a cup of coffee to actually being able to finish it. So even the simplest things like combing your hair, brushing your teeth have a lot of steps to them. So if somebody forgets some of the steps, that can be difficult. So just as I talked about before with memory, when you're looking at the last things the person learned, those are going to be the first things they start to have difficulty with. Things like operating a remote control for the television. And one of my friends whose husband has dementia, that's what she said right away, almost very quickly after his diagnosis, is that he started to have really difficulty. He still enjoyed watching TV, but the remote, with all those buttons, you know, he could push it and end up just watching snow. Real difficulty. It was kind of cool to see that there are now remotes that only have 1 or 2 buttons in terms of how they operate the TV, make it much easier for people. Being able to use the microwave, so maybe they've always used the microwave to heat up their meals. Now they're not sure how they should be using it. Often this is a place where you might see the person saying no, that they don't want to do something, like no, I don't want to brush my teeth. But if I don't remember all the steps about how to brush my teeth, that might be the reason that I'm saying no. One person said that he would always ask his wife to wash before dinner, and one day she didn't return to the kitchen, so he went looking for her. He found her in the bathroom door. She knew she had to go into the bathroom to wash, but she couldn't remember how to wash in terms of what was happening. So in the early stages, somebody might have trouble with the buttons on their TV or the remote, I already said. As the disease progresses, driving and cooking might be lost. He or she doesn't know that they need help. A person affected with dementia may who lives in the present but accesses the world of the past, when we're able to do all of those things, may think, why are you asking me to have a bath? You know, if I'm 40 years old, I would have already had that bath. They're acting on the information as if it's happening in the present. So the memories that they're getting, or the information that their brain's telling them, tells them I've already done those things, and that's why it can be difficult. They're acting as if they know what their brain is telling them is to them the truth. Imagine if you're not in this room, like I said to you later. That impulse control and are important functions. They may not appreciate the consequences of their behavior or how their behavior might make other people feel. They can get stuck on a task or a thought or a task, so they can kind of loop over and over. Typically, our brain would stop us from doing that, but their on-off switch, or that control, is changed, and so they may not be able to do that. The part of their brain, they're not in denial. They're just not able to realize that they have a disease that's causing them problems. And so for a caregiver, that can be difficult, as they might not recognize that they need that help, and be difficult when you're trying to give them some assistance. It's important to remain sort of non-confrontational, using that good body approach in terms of those nonverbals, using distraction, so a redirection, understanding that the behavior is not deliberate, and if they could control it, they would. Trying to insist that their reality is wrong and yours is right will produce anxiety and agitation, as they're not capable of remembering your point of view, your view of reality, and internalizing it. So the importance of looking at that and thinking about how that makes for changes. Sorry, distracted by my. So when we're looking at the next A that we're going to talk about, which is altered perception, that's when our 3D center of our brain is affected. It can help, or changes in depth perception. Our parietal lobe that I talked about before, that where our 3D center is able to tell us if something is real or not, and it's in the room, or if it's on TV. So sometimes for people with dementia, they can feel like the people who are on TV are actually in the room with them. They can have loss of depth perception, so they're thinking about an inability to judge how high something is, how deep it is, how long it is. That can affect the person's ability to perceive and move around in their world. So they can have trouble navigating the stairs, for example, if everything's the same color. So one of the suggestions about stairs, for example, is if they're the same color as the carpet, is to, so the carpet goes and the stairs go down and they're all the same color, is to actually put a strip at the end of each stair to help with the person's perception of where the stairs are. Sometimes when they're looking at something that's solid black or white, it can seem like a hole. What they're suggesting, that if you have a white plate on a white background, that makes it very much more difficult for somebody to find their plate. But if it's a colored plate on a white background, that makes it better, and it makes it easier for them to find the food and be able to eat it okay with no problems. And then the last A that we're going to talk about is that sort of loss of initiation or apathy. Thinking about the person loses their drive or their inability to use their initiative. It can look like depression. They may no longer become involved in a conversation or an activity because they no longer think to do so. It's that, so we can, things that can look like, or that are part of apathy, can be things like not saying hi first. So unless you engage the person in a conversation, they may not answer. They might not initiate that conversation. say, not going to church. So if you ask them if they want to go to church, they might say no. But if you get them ready and say, well, I'm going to go to church with you, then they'd be willing to go. If the person was depressed, for example, they might be willing to go to church with you, but then they, very shortly when they got there, they'd want to come back. The person with apathy, though, if you're with them and at church, they'd be happy to stay. People who have this need really have to rely on other people to cue them in order to be involved both in conversations and in activities in terms of what we're doing. So hopefully that's given you an understanding about the 7 A's that affect people who have dementia. So just the last sort of thing that I want to leave you with in terms of, before we start taking questions, is that those changes in the brain can alter people's behavior, their perceptions, and their coping strategies. But really at the core, people still recognize pain, joy, loneliness, and loss. It just might be presented in a different way. And when we're doing this, then we need to be thinking about where's that person with dementia at, and how